Good afternoon, everyone, and thank you for joining us for our webinar today. We're excited to welcome Dr. Nina Clark to the program. She'll present on the applications of telehealth for burn. We've reserved some time at the conclusion of her presentation for questions and discussion, and we have a few introduction and housekeeping slides before we jump into the actual presentation.
This educational activity is a project of the Texla Telehealth Resource Center, a federally funded program with the F. Marie Hall Rural and Community Health at Texas Tech Health Science Center and Wellhead, Louisiana, with generous support from Health Resources and Service Administration, or HRSA. CME credit is available for participants of this webinar, and a link to take the survey will be provided at the end of this presentation, as well as emailed to the attendees. These are just some helpful tips. Coming up are some helpful tips for our webinar and for ensuring you can receive CME credit if so desired. Please make sure everyone is muted, and please type any questions or comments you may have during the presentation in the chat box. Dr. Mitchell will now introduce our esteemed speaker.
Oh, no, I'm sorry. Just Derek. Sorry.
Dr. Derek.
Thank you very much, Anakin. And so Anakin has been a student assistant here at our department for a while, and today is his last day. And so we're forcing him to be our student presenter for today on his last day. And so we wish him best. He's soon to be joining the PA program down in the Permian Basin. So he's going to go on to bigger and greater things. So we're appreciative of that. Originally from Michigan, Dr. Clark studied human biology as an undergraduate at Cornell University before pursuing 2 years of clinical epidemiological research at San Francisco. She completed medical school at the University of California, San Francisco, prior to beginning her surgical residency at the University of Washington. At UW, Dr. Clark has become involved in research evaluating access to surgical care, particularly among rural communities and with particular attention to surgical emergency care. Her work evaluating the implementation of teletriage for burn injuries has been published in the Journal of American College of Surgeons and in the Journal of Trauma and Acute Care Surgery. Dr. Clark is funded by an NIH T32 grant through the Surgical Outcomes Research Center at UW and is pursuing a master's degree in epidemiology during her dedicated research time. She has also developed a keen interest in surgical education and has partnered with Behind the Knife to create a video atlas of trauma procedures, boards preparation material, and comprehensive curriculum for students on their surgical clerkships. She'll be pursuing fellowship and training in surgical critical care and acute care surgery after residency. We're honored to have you with us, and we will now hand it over to you for your presentation.
Thank you so much. I will try to share my screen. Give me just a sec. Let's see.
I just granted you some co-host privileges in case you didn't.
Amazing. Looks like it's working on my end. Do y'all see that? We're a go. Amazing. Well, you guys gave me a better introduction than I could ever hope to give myself. I'm Nina. I'm far from esteemed. That was very kind. But as mentioned, I'm a general surgery resident at UW. I'll be applying into critical care fellowships in about 1.5 years. So I will be maybe meeting some of y'all at some point in that time. And as was mentioned, we were able to publish two burn papers in the last year on the use of telehealth at our system, which we're really excited to talk about today. I have so many people to thank for helping both with these published papers and with putting together this talk, but here are a handful of my mentors and collaborators on this work across our Burn Center and the Harborview Injury Prevention and Research Center, including my co-author down here at the right, Lauren Agobi, who was my co-first author on both of our papers. So today, I think I saw that slide was maybe not updated from the last one. I'm definitely not talking about the eye. I was asked to talk to you all about the use of telemedicine in burn care, and we came up with the following 3 objectives. First is to discuss the indication, advantages, and applications of telehealth in the field of burn care. Next, we'll talk a little bit about how we can leverage technology to provide acute management and follow-up management for burn injured patients. And then third, we'll talk a little bit about special considerations and the logistics of doing this, especially in areas with large rural or underserved populations. Fortunately, this is a lot of what I was able to study and learn more about during writing up of these 2 papers that we published. And it's a lot of what we do every day at Harborview. So hopefully I can add a little bit of that color to this talk. Throughout the talk, I will structure things the way that our patients do, through the lens of the care that they receive in the pre-burn center setting, as inpatients, and as they follow up with us after an injury. I'll also try to both highlight what other institutions have done to come up with creative uses for telemedicine in these settings, while talking about the way that my mentors at Harborview have developed their system and implemented it within our regional context and at our facility. All of this understanding that the rollout and the use of telemedicine can be super dependent on what institution you happen to work at and what resources you have available to work with. There were a lot of trailblazers to emulate and learn from when Harborview started first thinking about building its telemedicine system for burns. And with the knowledge that we had about challenges faced in other settings with implementing burn telemedicine programs, we were able to further tailor our program with that in mind. So if you talk to any of the folks who actually built this system, they'll tell you about the quadruple aim of healthcare that guided a lot of their early decisions. And these aims really also serve as a guiding light when we develop not only functional, but sustained systems of care. First and foremost, we need to provide excellent, top-notch burn care to help our patients get out of the hospital, get back to work, get back to their families and their communities as safely and effectively as possible. And by providing excellent care, this is really the center of everything that we do and is really critical to our mission. Next, a sustainable system needs to be cost-effective. As you all know, I'm sure we're living in a time of incredibly pricey medical care. And if administrators are going to sign on to things that we propose, and if they're going to become something that we can afford to keep going year over year, they need to be cost-effective. And then finally, we need providers buy-in. You all could probably tell me stories about times when great ideas ended up into the dustbin because people who were actually supposed to execute the plan weren't engaged. And that very much applies with the rollout of any telemedicine intervention and was central to a lot of how we designed our system at Harborview. With everything we do, there's this goal to make providers' lives, if anything, a little bit easier, and at minimum to avoid major disruptions in their workflow, because we just know how busy everyone gets in the hospital and how critical provider buy-in is in making a system like this work. So excuse me, throughout this talk, you'll hear me and see me refer back to this figure a bunch just to show how we've tried to think about each of these aims in how we evaluate them as we now grow into a more mature telemedicine burn system. So first, let's get into a little background. I probably don't need to tell most of you that burn care, especially in the Western United States, is quite regionalized. This map is just each dot represents an ABA verified burn center. And you can see that burns are also common. They impact about 500,000 patients every year in the United States and result in a huge amount of medical and work loss costs that impact both the patients as well as our healthcare systems. That amounts to over almost $6 billion a year in the United States alone. And you can see that folks like yourselves out here in Western Texas and us up in the Pacific Northwest are quite isolated when it comes to the distribution of burn care centers across large areas of landmass. These pictures are from another paper that was actually just published last month, where they calculated the linear distance to a burn center. And here the purple represents those really remote areas with the nearest burn center over 700 miles away in some cases. And you can see that on the right side of the screen, the pediatric burn centers are even more sparse, especially in the middle of the country. And note this, that these maps didn't include Alaska, which we often will serve out of the University of Washington. Again, what this shows is that our patients are traveling sometimes hundreds of miles when they need burn care. What this distribution of burn centers can lead to is an overburdening of those centers. They already treat about 25,000 patients every year for burn injuries and serve these huge geographic regions. And they receive consults based on the ABA or American Burn Association consultation criteria, which tends to be quite broad and can result in referrals for just a ton of patients. What this means too is that a large amount of burn care is actually happening outside of burn care. So there's about 40,000 admissions for burn injuries every year in the United States, which means that almost half of that care is happening at regional centers that are not ABA verified burn centers. Presumably those are milder injuries, but it's an important consideration that a lot of this care is actually happening outside of our kind of hollowed halls of the burn center. This is just a snippet of those burn referral criteria. This is for thermal burns. The ABA recommends consultation for any full thickness burn and any partial thickness burn over 10% TBSA. So you can just imagine how many patients fall into this category who at very minimum are getting referred to a burn center, if not actually transferred to it. It's often really dependent as well on referring providers to interpret and initially assess these patients. In our experience at our center, this often results in an overestimation of burn size or depth, which can make things really tricky when you're trying to remotely assess whether a transfer to your center is appropriate, particularly when you know your center is well over capacity like ours has been over the past 5 years. These issues exist nationally, but when it comes to rural areas, they can be particularly salient. In just the last 2 decades, we've seen huge numbers of rural hospital closures, which results in more disparate care for patients living in these areas. Burns are also becoming less common over time, meaning that low volume centers in a rural area may have just a few burn injured patients presenting to them each year. And providers may just be becoming less familiar with the evaluation and management of burn injuries, which can lead to additional consultations with the burn center. When you combine this with the overall lack of burn care in rural areas overall, you can end up with really busy regional burn centers. This is how it plays out in Washington State. This is older data, but the last time we looked at this, we found that of the total number of burns in our state, Harborview at our burn center takes care of, as you can see, the vast majority. And especially during COVID, when our ICUs and our floors in the hospital were often quite full, you can imagine how this distribution of care was really challenging. And this is what inspired a lot of our work, looking at whether telemedicine could play a role in evening out this workload across the regional system. If we can increase the capacity to care for minor burn injuries in other hospitals, then that means that some beds might open up for the really sick patients who actually require the care that our burn center is uniquely capable of providing, that they can't get in smaller or less resourced settings. And then here's another map. This is more recent data showing our burn consults from the last couple of years. And again, just demonstrates a huge geographic region, which again will likely be familiar to many of you, that shows again the potential for telemedicine to really impact patient care when traveling for an in-person admission or a clinic visit may actually mean traveling thousands of miles, maybe crossing a country or two, crossing multiple mountain ranges in our case. This also incorporates data from over 5,000 calls that we received in that 2-year period. So you can just imagine how much volume this ends up looking like. So we can see some clear issues with the current structure of burn care in the United States and potentially a clear role for telemedicine to mitigate issues related to a lack of access to burn care. Telemedicine and teleburn care have been proposed as one way to facilitate remote assessment and even management of burn injuries, expand capacity in rural areas in particular to provide burn care, facilitate coordination of care across large geographic regions and multiple providers, and potentially to provide better care to patients while also improving the comfort level of providers who don't see burn injuries very often, or for those who are caring for the most severely injured patients at a burn center. However, the implementation of telemedicine brings its own challenges, and that's what we'll mostly focus on today as we talk. Before we get too far into the use of telemedicine and burn in the pre-hospital setting, we have to acknowledge the early leaders in this space. Institutions in several other states with large rural areas, including Utah, Minnesota, and Iowa, were some of the earliest adopters of telemedicine for burn care. And the folks who lead Project ECHO, which many of you are familiar with, since 2003, have been working on ways to incorporate this remote outreach in the way that we collaborate with and educate providers across systems and large geographic regions to improve the care that they provide their patients. So we're by far not the first to incorporate or study these systems and really have been able to stand on the shoulders of some of these giants in developing our system at Harborview. This is from a talk that was given to one of my mentors by Dr. Lynn Solom of Minnesota. He was one of the early adopters of a regional telemedicine system showing what they called the hub and spokes model for their regionalized burn care. And you can see that this extends across much of the upper Midwest. This system was rolled out in the late 90s, and at the time, the investigators estimated they were saving patients an average of 440 plus miles of round-trip driving with every telemedicine visit. And at the time, they were already experiencing some of the same limitations that you'll hear over and over if you talk to telemedicine providers today. How do we bill for this care? How do we ensure that we're accurately assessing injuries? Do we have the appropriate and functional technology to do this care? And then finding an appropriate balance between the efficiency and convenience of telemedicine with providing good quality medical care. And then look at what he was talking about back in the early aughts as the future of telemedicine in burns. Hopefully many of these points will look familiar to those of us who work in this space today, but he was already talking about things like expanded follow-up for burn injured patients, using digital photos, email, and phones to consult providers, consulting in remote regions, getting a 24/7 acute consultation service, and leveraging new technology. So really all of this is stuff that you'll see as we talk further about how this technology is being used today. Good foresight. This is a similar program that was implemented in 2004 in Utah and was published in the JOT in 2009 by Jeff Saffel and his colleagues. In this system, every participating center, which you can see their region here, was actually given a physical computer setup. This is very similar to what our workstations still look like at Harborview in some cases. And they looked at a handful of outcomes prior to implementing this system and afterwards, showing that prior to use of teleburns, they had 100% of their regional referrals transferred to their facility by air. So you can just imagine how costly that care was. After implementing teleburn, that number went down to 44%. So they were already seeing some distinct changes in the ways that they were triaging and transferring patients to their facility. This was also one of the first groups to look at burn size estimation with telemedicine versus in-person, and they found decent agreement, which was, again, a positive sign for the utility of this tool going forward. Finally, they surveyed some of the patients and providers who participated in the teletriage system, and a couple of highlights from that survey were noted to be potential barriers for wider adoption of telemedicine in burns, including challenges with burn depth assessment, difficulty getting the equipment to work, and adoption by providers, or what they called cultural change. They noted that at this time period, about 10 patients were just transferred to their facility right away without using telemedicine because the providers weren't really interested in it at the time. So I think, again, showing some of the early concerns that are still a little bit lingering today, even 20 years later after this system was implemented in Utah. So now we'll start getting into it. We'll start with the ways that we can use telemedicine in the pre-burn center setting. And this is really both the best studied and probably most heavily utilized aspect of telemedicine for burn care. Plus, it's where my current research factors in. So I'll spend most of my time today talking about this. So one of the first and most long-running roles for telemedicine in burns includes care in the pre-hospital and pre-burn center setting. Most of this comes from global health literature, where triage in austere settings has been traditionally very challenging. But really, since the 1990s, these systems that we talked about in Minnesota, Utah, and Iowa have been using telemedicine to assist in the initial assessment of burn-injured patients in the rural United States. Well, at first, this was really focused on getting an accurate assessment of burn injuries to avoid under triage or missing severe injuries. In more recent years, there's been this increased focus on avoiding transfers to a burn center when care can be appropriately managed at index facilities. And literature supports that about 50% of our burn transfers might be avoidable. There's unfortunately not one universal definition of what constitutes an avoidable transfer, but folks typically will use a definition of a short stay under 72 hours or so without operative intervention or an ICU admission. Transfers are expensive for our patients and for our healthcare systems, and transfers for burn patients, from remote areas may be made even more costly because they might need things like air transport or advanced life support en route. Finally, as those of you who care for burn injured patients can no doubt attest, these are not short-term kind of one and done type injuries that you can fix and just send home. They require intensive community and healthcare provider support and rehabilitation. So separating our patients from their support networks can make this whole process much more challenging. And finally, when regional referral centers are full, it can further limit access to care for patients who actually need it the most, which can cause major problems when there are limited options for advanced care within a region. At this point, over 80% of US burn centers are using some sort of telehealth to care for their injured patients. And fortunately for us, this has been studied pretty extensively in the ways that those systems can fit those quadruple aims. Research has pretty consistently shown that teleburn evaluation can result in more accurate assessments of TBSA and burn severity, can lead to increased effectiveness in triage and transfer, is cost-effective for providers, patients, and the healthcare system, and is generally found to be acceptable by both patients and providers who have adopted it. So we've got a lot of data that's already supporting the use of these systems for pre-burn care. There we go. Something I think a lot about when it comes to that last point about the acceptability and adoption by providers and patients is the infrastructure that you actually need for these systems to work. And fortunately, the more mobile technology is advanced, the easier this has gotten. Those earliest systems, like the one in Utah, some of which are still in use today, essentially provided both receiving and referring hospitals with computers that were equipped with photo and video equipment to do a teleconference call. So you'd have a station that you could go to reach a provider via telemedicine. Some clinics still have these hardwired today, but we can also advance further from that. And that's part of what we've thought about a lot at our system at Harborview. iPads with teleconferencing apps pre-downloaded, cell phones with a camera and a secured and HIPAA-compliant messaging app, even the electronic medical record can provide a lot of what we used to need specialized equipment to provide. And more of these technologies are familiar to both providers and patients, and in many cases, quite easy to navigate. I'll talk a little bit about the use of public platforms like YouTube to disseminate knowledge as well a little later in the talk. But in all, we have many more options than a special telemedicine computer station in your hospital when it comes to today's burn care and teleburn care. Another critical component of any system like this is the people, whether it's a method for notifying burn providers or practitioners directly when a new consult's coming in, or if it's devising a system to filter new consultations. Some of the earliest systems that were developed in teleburn would ping providers immediately on the receipt of a burn consultation, which might work well if you have a relatively lower volume institution, but would be a real challenge for our providers who receive thousands of consultations from outside facilities every year. So we really had to think about rolling this type of system out and how do we balance provider satisfaction and ability to do their actual clinical day-to-day work with the costs and need to ensure that we were still providing excellent burn care to our regional systems. So when it came down to it, Harborview leveraged the existing infrastructure that we had access to already at our institution. We had a triage nursing staff that already mans the consultation line for our hospitals. We all carry around a cell phone at this point, have access to secured emails and secure EHR messaging, and we had public platforms like YouTube, which we were able to leverage. I want to focus on the triage nursing staff especially. Like I mentioned, they were already part of our hospital infrastructure. Fortunately for us, we have this really robust transfer center that receives calls from our entire region. And so the triage nursing staff was already trained in collecting basic information about all sorts of transfer patient populations. And we've worked specifically with them to train them to collect both the information we need to accurately triage burn patients, but also to have this really unique role in that they provide advice about initial wound cleaning and care to help referring providers be able to give us useful information when we eventually do discuss patients with them. By keeping the triage nurses at a critical and central part of the system, this was part of how we found that balance in providing referring facilities with excellent service, but ensuring that our providers were receiving the right consults for the right patients with the right information and the pictures that they needed to do an actual good job in triaging patients. So this is the general schema for what our system looks like at Harborview. Again, we have this open consultation line with our regional providers managed by the triage nursing staff between our burn hospital and our regional hospitals. And those triage nurses will help with referring providers determining whether their patients have a severe or a more minor injury, and they'll facilitate triage accordingly. At the end of the day, even those minor injuries will have some form of follow-up with our burn center staff, even if it's just a check-in phone call or a clinical referral after their acute episode. The question of licensing always comes up here, particularly because for our system, these calls from outside facilities may be becoming from other states. All but one of our burn providers are only licensed in Washington state. So these calls are actually clearly identified as education or advice to outside providers when we first discuss the patients with the triage nursing staff, so that we clearly identify our role as essentially expert advisors in early burn care or triage, while encouraging and empowering referring providers to actually be the ones providing the definitive care for their patients. So that's kind of how we get around the fact that this is crossing state lines in many cases. This is just a picture that kind of illustrates the sort of work that the transfer center nursing staff helps us with. One of our burn center attendings likes to say that calling a burn without a clean wound is sort of like calling ortho without an x-ray. And this picture really demonstrates why. At that initial consult photo, you can't really tell what's going on under those large blisters, but you can see that there's this pretty deep burn, particularly over the fingers. Once it's been debrided, by the time you can see my attending's head popping up in the bottom of those second series of pictures. By having trained triage staff helping us, that means that burn providers who are in and out of the operating rooms and clinics all day aren't spending their time guiding a referring provider through this initial wound care for these patients, but rather they're seeing a cleaned up wound. They're getting a really good sense of these injuries by the time they need to actually make a decision about whether to transfer the patient or not. In the next few slides, I'll walk through how this actually logistically happens at Harborview. So this is a busy slide, but we'll take it step by step. But basically in 2016, we'd had about 5 years of telemedicine and burn teletriage under our belts. And we started to notice a handful of patterns about the types of calls we were getting. So we used that experience to develop what we now call our color pathway system for burn referrals. This whole system goes from the left-hand screen of the screen toward the right, and every patient referred to our center through the triage nursing staff will get triaged onto one of these 4 pathways. It all starts with a new burn consultation coming in. There's a conversation between the triage nurse and the referring provider that focuses on the relevant clinical and burn injury history, and then maybe some of those early photos like you saw in that last slide. We will essentially take any photos that the referring providers will give us. If we have the ability to share them securely over the electronic medical record, our system currently uses Epic. So if the referring providers have Epic, it's great because they can actually securely upload pictures to the chart, and that's a great way to share images. But we also have a secured email line that they can take pictures on their cell phone and use that as an alternative. So there are a couple of different options for our referring providers so that we can, again, get really high quality images ideally. Based on that information that the triage nurses collect, they then will triage patients onto one of the 4 color pathways, which determines essentially everything that happens next. So the green pathway represents the most minor burn injuries. This is essentially a request for burn clinic follow-up that's entirely managed by nursing staff. They will provide the referring providers with some initial wound care advice that we've trained them to provide, and then we'll give referring providers and patients access to a series of YouTube videos that reviews basic wound care and stretches relevant to the injury. And then they'll arrange for appropriate outpatient follow-up either via telemedicine or in clinic physically. Within 24 hours, all of these requests are reviewed by a senior burn physician, just to ensure that no severe injuries have slipped through the cracks, and tweak follow-up plans if necessary. But in general, these calls don't result in a page or a call to anyone who's on call when they initially come in. And so this green pathway is really critical to that provider adoption piece, because again, if we're not paging on-call providers, that means that for all of these calls that people get to sleep through the night, they don't get an extra page to their cell phone that they have to triage when they're in the operating room, etc. Next up is the blue pathway. This represents potentially more complicated injuries or injuries that referring providers just have some more questions about. Basically, if at any point a referring provider requests to talk to a burn doctor, even for a minor injury, the patient is at minimum bumped to the blue pathway, sometimes to a higher level pathway. In these cases, these are still generally pretty mild injuries, so the triage nurses will provide that initial education and advice to help providers to do an initial wound cleaning, which means that by the time the burn physician is looped into the conference call, there are usually some updated photos available that allow us to, again, really be able to assess the injury more accurately. We then have a conference call with the referring providers and determine whether transfer or outpatient follow-up is most appropriate for that patient. Next up is the red pathway. This is for moderate severity injuries or injuries where the referring provider otherwise just doesn't feel confident or comfortable caring for that patient within their context of their resources. So these calls are more quickly triaged to our burn providers at our center, so we can discuss with referring providers about what's going on, the comfort level that they have with caring for these injuries, the resources they have available to them, and whether a transfer is appropriate for that patient. And then finally, the black pathway is the most severely injured patients. These are our most urgent consults. These are rapidly triaged to the on-call burn physician so that we can facilitate rapid transfer, while also allowing us to be part of initial conversations about things like airway management and security, initial resuscitation, etc. The Black Pathway also gives our teams a chance to mobilize in the burn ICU and in the emergency department to ensure an efficient transition of care once the patient actually arrives to our facility. This is kind of nice because if you get one of these calls, I've gotten them from Alaska before, and it's like they're 8 hours out by a fixed wing plane. So you have a lot of time to get your team in place before things are actually moving down in the ED. So that's a system that we rolled out in 2016. And again, the triage nurses are really the heart of this operation. They facilitate both the triage itself onto one of these pathways, and then all ongoing conversations between the providers at the referring hospital and the burn center and the transfer itself all go through them. So they're really the center. Oh, I'm sorry, someone's saying. Okay.
We might have someone off mute. We'll work on that.
No worries, no problem. Okay, just wanted to make sure I wasn't blown through somebody. And again, to just illustrate the power of this system can have, this was a consult that we got to our service, and we were asked to provide some initial insight as to what the referring physician should do with this patient. And you can see some signs that we might be dealing with a deep burn here, but in reality, you can't really tell exactly what the wound care plan should be. And this is what this wound looked like after they cleansed it. And this was guided again entirely by those triage nurses. And you can see that we're dealing with a pretty severe burn here that's relatively large and crosses a joint. And so this patient did eventually transfer to us, which we might not have necessarily agreed to or known about coming in. So again, it just helps with really getting an accurate assessment of these injuries when we have those triage nurses kind of guiding a lot of that care. So that gets us to our first paper that our group published, looking at the implementation of this system and its impact on things like provider workload and triage accuracy. We implemented this system, like I said, in late 2016, and then spent about a year training triage nursing staff and providers how to use it, and then kind of formally rolled it out. And this is just a chart showing the number of patients that had one of those triage pathways documented within their chart. And you can see that through the dedicated work of our burn center staff, we ended up with really, really high adoption of this system overall, with over 98% of our burn consults being triaged to one of the pathways and actually having it documented. And that documentation component is really critical for our ability to perform ongoing quality control checks and research using these data. So it's been sustained now for well over 5 years. This was back in 2018 that this kind of shifted, and it's been going strong ever since. We looked at data from the 2 years that we had near complete recording of pathway information. So this is 2018 and 2019, to just see how this pathway system impacted provider workload. And you can see that around 75% of our total burn call volume encompasses lower acuity burns in the green or blue categories. And we saw that this system was really effective at reducing calls to on-call providers, with nearly 1,000 calls total, or 40 calls per month, falling into that green pathway that, just as a reminder, are managed by triage nurses independently of whoever was on call for the burn team. Notably, about half of those green calls occurred overnight, and about a third of them occurred over the weekend. So you can see that this has direct applications for the number of pages that we're answering as physicians on call. Over time, we saw that use of the red pathway in particular decreased, along with a decrease in the proportion of patients who were actually transferred to our center off of the red pathway. And then again, keep in mind that those red pathway patients typically have sustained burns that referring providers don't feel confident managing on their own. As the proportion of the patients assigned to the red pathway decreased with time, there was this relative increase in the use of the blue pathway, which may indicate that referring providers and triage nurses might be learning how to more accurately triage low acuity patients, and might be becoming more confident and comfortable caring for burns locally in circumstances that would have resulted in transfer in the past. Next up, we get to our second paper, where we looked at the impact these triage pathways had on those potentially avoidable transfers. So for this one, we studied all transfers to our facility over a 10-year period and looked at those that occurred before we rolled out the teletriage pathway system and those that occurred after the pathways had already been adopted. I mentioned before how there's no one universal definition of these potentially avoidable transfers or over triage to a burn center, but we were pretty strict in this paper, defining our over triage patients as those who had been discharged to home within 24 hours without a trip to the operating room, an ICU admission, or any noted concern for non-accidental trauma. After we implemented our teletriage system, we saw an 11% reduction in short stay transfers. At the same time, we saw that transfers in the post-implementation period had a longer median length of stay and a shorter median time to operative intervention when compared to patients in that pre-implementation period, suggesting that patients who were transferred after we started using this pathway system required a higher level of care or access to more resources, possibly because they had more severe injuries, which was really the whole impetus behind this system to begin with, was more accurately triaging patients who really needed burn center care. For this study, we also did an interrupted time series analysis that looked at the predicted proportion of potentially avoidable or short-stay burn admissions after transfer before and after that triage system was implemented. And again, you can see this near immediate drop in the proportion of avoidable transfers after we started using this system, which amounted to a 17% reduction in the adjusted likelihood of avoidable transfer. So again, this seems to be effective at reducing those potentially avoidable transfers. So we see this clear role for telemedicine in the pre-burn center setting. It can help us refine and improve triage. It can provide cost-effective care, and it can facilitate local care in ways that we maybe were more reluctant to provide in the past. And then as these systems mature, they can also be leveraged to build capacity across regional systems by building that confidence for regional providers. And then work within our own system shows that we can leverage this technology that's already in the hands of most of our providers and patients to develop systems that are both acceptable to providers and reduce unnecessary care and transfers for patients who don't ultimately need burn center care in the acute setting. So next we'll move into the inpatient setting, which is not typically a setting where telemedicine has been thought of as like a critical tool, but is definitely one of the less studied aspects of teleburn, but I think is actually an important part to consider nonetheless. If any of you have cared for a burn patient recently, you know how important and how resource intensive that daily wound care and those detailed wounds assessments can be. We are constantly grappling with the need to regularly evaluate burn wounds in their various stages of healing, with the limitations of our busy daily jobs in the hospital, staffing restrictions for what might be very resource-intensive exams, and the degree of invasiveness involved in having the entire burn team show up at a patient's bedside while they're exposed and made to go through what can be incredibly painful and invasive wound care. Many of you have also had a big burn come in who needs an active resuscitation and extremely close clinical monitoring. I know I've had to park myself physically inside of a patient's room before just to keep up with some of these really active resuscitations, which can become really difficult if you have another sick patient you want to see or a case going in the operating room. And again, at Harborview, when we started thinking about how we could do this, it came down to that quadruple aim. We were in the middle of COVID for a lot of this, and it meant we were exposing burn patients to fewer people overall. So by implementing things like Zoom rounds, we were actually improving the care and infectious exposure that we were exposing our patients to. We were using less PPE, which I think every hospital would have liked during that time. And we were actually improving the educational experience of rounding on patients with burn wounds. We were at first concerned about the educational exposure of residents and students on our teams, if we were going to reduce the number of providers in a room at a given time. But what it ended up being was our senior fellows or the attendings were taking one or two residents with them to round on patients with a Zoom camera. And it meant that the rest of them got to watch and actually probably get a better view of the wounds every day. As we were then talking through our exam findings and plans. So it actually ended up being an improved educational experience for quite a few of our team members. So in our system, we've leveraged telemedicine as a tool that we can use to improve patient care within our own hospital with patients we're already seeing physically every day. And we can use the same methods and tools for evaluating burn wounds to share photos or videos with our entire multidisciplinary burn team. We can use secure messaging tools to ensure that bedside nursing staff and residents are involved and updated about changes in big burn resuscitations. And we can leverage these tools to improve the care that we take of our patients, as well as the educational experience of trainees on the inpatient units. This is just a before and after of how this used to look. So previously we'd have these huge groups present to round on our patients with large burns every day, one of whom, and then, yeah, after we implement this system, we ended up with just, 2 to 5 people in the room at a time, one of whom is holding an iPad and showing the wound to the team in the conference room. explaining what's going on to the patient, showing the additional people who need to see and continually monitor these wounds, what's happening. But those people are sitting in the comfort of a conference room and not infecting patients and not kind of crowding in on that space. And as we progress and patients come into the hospital and receive care, we can use tools like the stored photos that we place into the medical chart to monitor their progress and their healing. Our interns love this because they take a picture and immediately can run upstairs and show their seniors and burn fellows what they just saw in the emergency department. Our staff love it because if they take a weekend off, they can still keep up with the progress that their patients have made over the course of the weekend. Our nurses will regularly upload Lund Browder charts so that we can get regular updates on wound healing and progression. These are just a couple of ways that we can leverage the technology that's already existent in much of our EHR systems to make our lives easier, even in settings where telemedicine hasn't been a traditional focus. I just learned the other day that we have a hospitalist who's actually working on taking the charted daily Lund Browder charts to estimate length of stay. So you can see that some of these tools can actually be leveraged for real impact in our hospital systems and for our patients. So for inpatients, telemedicine can be a huge tool to improve the patient and provider experience of things like wound assessments, inpatient rounds, and inter-team member communication. And last up, we're going to head to the clinic, where again, this has got a long history of telemedicine being used in innovative ways to help patients with burns. Again, why is this important? I'm just thinking about patients who I've personally cared for, and I can come up with a couple of examples why I would maybe consider telemedicine. For example, what if patients are triaged via that green pathway and they never actually needed to come to the burn center, but might need our help with therapy or later scar revisions or operations even? What if patients are low income or from really far away or live in a geographic region where accessing follow-up care at our clinics is not straightforward? These are some areas where burn clinic follow-up can be greatly benefited by the use of telemedicine. We've also seen the issues that can arise if patients don't follow up with us. Things like infection, contractures, functional limitations, untreated systems can all really impact our patients' chronic well-being and ability to return to their daily lives. So in all, it's pretty critical for us to make sure that we provide equitable access to quality burn care even after an acute burn is dealt with. Fortunately, many of the tools we've already talked about within telemedicine can easily be applied within this setting. We can do just-in-time training and triage. We've talked a little bit about YouTube. I'll talk more about that next. And then we can also use tools like Zoom and teleconferencing at the time of clinic follow-up. One of the ways that we do this at our system can start even as soon as that initial triage call. Part of what our triage nursing staff does is provide some initial wound care advice and access to educational materials at the time of the initial consultation with our burn center. And part of that process is providing access to this repository of YouTube videos. These are literally public YouTube videos. You can access them from anywhere. Patients like them because they don't need any special accounts or devices to access them. They're short and they're developed with our experts from the burn center, including both the burn surgeons and our burn therapists, to really target the most important aspects of care for specific injuries. So this is just meant to be a really accessible tool that patients can use again and again, as can providers. This is what they look like. So again, anyone can go onto YouTube and look for these. And when we get a new burn consultation, the triage nurses will pick a subset of these videos to help both the referring providers to do an initial debridement of a burn injury and for the patient to learn about relevant stretching and wound care. We will teach parents how to stretch pediatric hand burns to avoid contractures. We'll teach providers and patients how to apply dressings and cleanse wounds. Basically, every aspect of straightforward burn care is accessible. It's on your mobile device, and it can be watched over and over again if you forget anything. And remember how we looked at the use of those higher acuity pathways in our system over time and saw that they had decreased since we started using the system to triage patients. I think this actually has a lot to do with it. If you're a provider at a small community hospital who rarely cares for burns, but we've walked you through it a handful of times and provided you with a trusted resource that you can go to the next time you see a patient with one of these injuries, maybe that makes you less likely to request a transfer in the future. And then these videos will progress throughout the entirety of a patient's journey with their injury as well, including post-op care, pre-op care for patients we see in clinic who need an operation, and post-discharge wound care. And again, just a reminder that sustainable systems need buy-in from staff just as much as patients. And these have really been championed by mainly our clinic and our acute care inpatient nursing teams more than anything. So again, that staff buy-in has been absolutely critical to making this system work. Finally, traditional telemedicine follow-up and clinic appointments. This has been well studied and documented over many years, and really took off during COVID as a way to increase the accessibility of burn care for patients. And we took advantage of some of the policy level changes that were going on at the time, like out-of-state licensing restrictions that were dropped during the public health emergency, which allowed us to follow up with some of our out-of-state residents more easily using telemedicine. This is just a map that shows those restrictions and lightening of restrictions that occurred during the public health emergency. And to this day, we are still kind of grappling with the loss of those lightened restrictions in the telemedicine space. Unfortunately, as most of us have probably experienced, Zoom can be extremely exhausting and pretty unsatisfying when it comes to something we're using every single day. So as we've matured this system, we've really needed to find a new equilibrium that kept the things that were great about telemedicine follow-up care for burn patients, stuff like easy and cheap access, but also got providers on board instead of just making them fit into a system that didn't provide us with the satisfaction that we get from seeing our patients in person in clinic. Just a funny quip about the Zoom CEO already had Zoom fatigue. This was in 2021, so I think we can all feel that pain. So how did we do this? We integrated these video visits into our Epic platform, so they were given the time of day, just like in-person visits were. We addressed licensing restrictions that came back into play after the public health emergency was completed by having one of our clinic ARNPs obtain his license in basically all of our referring states. We established a special Zoom clinic room, which is physically located within our clinic, has a physical dedicated space. And just like for an in-person visit, the MA will actually room these patients. They'll take down their initial concerns. They'll spend a little time with them, ensure everything is up and running. So as providers, all we have to do is walk in and turn the camera on. So essentially, we've tried to make the clinic experience for a Zoom visit the same as or as similar as we can to an in-person visit. And speaking as somebody who's led a handful of these, it's much more rewarding when they're already up and running and you don't have to fiddle with the tech. Now, this is not without its challenges, and as we benefit from the convenience of Zoom visits, we're also moving into an era where it's really a part of what we do, but we need to structure this in ways that we're still providing trainees with appropriate opportunities to participate in outpatient care, while also ensuring that this access and these technology is equitable and available to patients across all sociodemographic groups. So these are some concerns and pitfalls that we'll probably face as we move into the digital era further in healthcare. But you can see that there are clear ways that this has been a really positive rollout overall for our providers and most importantly for our patients. This is just a quote from Beth Costa, one of our newly retired burn therapists, but the patient didn't even need her in clinic. He showed me all the hand stretches from the YouTube video, and this was his very first clinic visit. So you can see the power of some of this stuff when it comes down to individual patients as well. So once again, we see clear roles for telehealth in outpatient burn care with some potential challenges we need to be mindful of in the future. While telemedicine can be leveraged to increase regional capacity for burn care by training regional providers in the basics, allowing patients to have the autonomy for care in their own injuries, and reducing the cost and inconvenience associated with outpatient follow-up. But we also need to ensure that these systems are equitable and continuing to fill all four of those quadruple aims, accounting for the provider and the patient experience and their outcomes. So what might we see in the future? We might see some policy change that allows us to do some of what we started doing in the pandemic, namely developing reimbursement and licensing policies that facilitate local care for our patients. There might be expanded roles for what we can use telemedicine technology for in the acute inpatient settings, both at our own facilities and by providing remote care. And our institution is actually starting to work with our therapists on advanced ways to continue supporting and providing patients access to burn therapy after their acute admission is over. We're actually developing an app that will allow us to do ongoing patient wound monitoring. And even though we've got this vulnerable population of patients who've had burn injuries, I think the surface has barely been scratched in terms of the ways that we can leverage this technology for our patients. And all the while, we need to really keep the following things in mind. First is ensuring that everything we do is aimed at providing more equitable access to care so that we don't leave patients behind as we advance forward. Next is focusing on provider as well as patient satisfaction with changes that we implement. And then finally, maintaining an emphasis on quality data collection and high integrity data collection. As somebody who had to manually pour over thousands of records of transfer requests, I can attest that the system definitely could still be improved. So using some of these systems to also leverage data collection for research and quality improvement in the future is going to be critical. And just a reminder that sustainable change takes work. None of this happens overnight. One final example is our institution's work partnering with the Alaska Native Medical Center. This is a facility up in Anchorage that's about 1,500 miles away as the crow flies from Seattle. But we've not only shared patients over the years between our two centers, but we've collaborated on research projects. We've co-moderated burn outreach in our respective communities. And we've developed this really robust platform actually through Project Echo for collaboration and continuous learning across our systems. And this is really what can result from dedicated action and leveraging of these tools, including telemedicine, to provide excellent care to our patients and to our regional communities. My attendings love this quote from Dr. Saffel at the U of U, but when it comes to teleburn care, I think it really applies that we're not talking about the technology necessarily, but about the service that we can provide to our region and our patients. And hopefully this talk today has given you all a framework and maybe some ideas for how this can function as we continue to navigate our healthcare system, try to provide the best care for our patients while also caring for our teams and ensuring the longevity of our healthcare systems. Thank you for the opportunity to present this, and I will happily take any questions. This is our two papers and then a link to our YouTube site.
Okay. Thank you so much, Dr. Clark. That was a great presentation.
Thank you.
Yes. To the audience, don't forget to fill out the session evaluation survey to obtain your CME credits. You can access the survey by scanning the QR code on the screen, and a link to complete today's session evaluation will be emailed to all participants as well. We will now open the floor for questions and discussion.
And I believe we have Dr. Santos, our PI, as he's on as Jennifer. I didn't put two and two together, so I apologize.
No worries. I'm using my wife's Zoom link because I'm having problem getting in. But Dr. Clark, thank you very much. And I would like to personally congratulate you for your publication and all your work on teleburn. You know, I've been following you closely. And I review one of your study that was published in the East manuscript that I personally reviewed. So I'm really proud of all your work. And I would like to acknowledge as well, SCCM surgery section, helped in putting this together. And Dr. Lee is actually, I saw him log in a while ago. I would just like to ask if you use, modern technology like AI, as well as there are some app, measuring the total body surface area burn, as well as the depth of the burn, because it's very important on resuscitation as well as management of burn patients. So have you used those in consonance with your triage and teleburn? And number two question is, I've been having probably average of 4 calls regarding burn. We have a burn level 1 burn. We have burn center here at Lubbock, Texas. And it's relatively, it's really very busy because we serve a huge amount of catchment area. So I put it in the chat there, kind of very quickly, tips or tricks on how to put this together if we're just gonna start it. Thank you again.
Thank you. And thank you. Yeah, you have been a part of this work from really the start. So it's nice to see your face. I think to your first question, the role of AI, I'm like almost a Luddite in this, in that I was like completely unaware until recently about all of the things that AI has in terms of potential for burn care in particular. And I think my co-author Lauren on these papers likes to talk about the app that can actually like identify a croissant and place it to the right bakery in Paris. And so I think that we are coming up on a time when we are going to be able to like apply that technology to a burn injury and see things like depth, see things like TPSA. We have not specifically implemented anything like that yet in our system at Harborview, in part just because, again, this was meant to be a really easy entry, kind of low barrier system. And I think that's part of why it's been so highly adopted, is because we're literally using cell phone pictures and email. It's nothing fancy. So at this point, we haven't yet done that. But I think as AI becomes more and more accessible, that is going to change. And I think there is a huge potential role here for remote burn care when we can get more accurate. And once we've validated systems that will be able to accurately assess both TBSA and burn depth, I think in particular. We can accurately estimate TBSA. It actually works quite well, and there's decent concordance between our teletriage pictures and the eventual injury once we get them to harbor view. But what is really difficult still, even with the clean burn wounds that we see, can be assessing depth and likelihood of progression. So I think that's a huge space for improvement. The second question about kind of rolling this out, I think, you'll hear this with any like implementation scientist here, is that like you need provider buy-in, you need the system buy-in. And I think that's what we really did a nice job of. I think regionally in our system, we have this huge catchment area, obviously patients coming to us from remote areas in Alaska, for example. So when our my bosses started this system at Harborview, what they did was they started having regional meetings, and have actually kept up those regional meetings to this day. So they're pretty regularly meeting with actual referring providers who are out there referring patients to us using these pathway systems. They're getting regular feedback on how this works. They're getting early feedback on, things like my Epic won't log in. What do I do if that's the case? So I think two things come to mind to really quickly and scratch the surface of how to implement something like this. But first is thinking about those like low barrier to entry things, using technology that we're all have it in our hands at all times. And then second, to really engage those stakeholders and the people who will actually be on the ground and using this, and make the argument for them that this is actually going to make their lives better and their patients' lives better. Because those are things that I think we've continually focused on as we've developed this system. And as it's matured, it's always matured with those things in mind.
Is there anyone else in the audience that had some questions? I want to say that I really appreciated that you covered the topics of education in both the facets of provider education and how you were able to use telehealth to do that. That's very important. I think that's a great part of it. Education is a big part of, what we do. And so also patient education on them and being able to access it. Did you have a lot of barriers with patients was there a steep learning curve teaching them, hey, now you're going to do this, or did you guys kind of overcome that pretty easily?
Honestly, I've worked with a handful of a bunch of patients over the years who have done the YouTube stretches and the videos and stuff. And I think honestly, at this point, it's familiar. My grandmother is on Facebook, right? I think it's actually, that was a big concern when we first rolled this system out. It was like, what patients are we missing? And certainly, as I mentioned, that's a concern going forward, is that we need to make sure that we're not leaving somebody behind importantly, as we develop things like this. But, in today's day and age, most people are confident going on the internet and looking at a video. And when we make these videos, we're making them now in multiple languages. We're providing them at, a high school or lower level of health literacy. So they're pretty straightforward, and they're all 2 to 5 minutes long kind of thing. So they're just really accessible. And so I've actually been surprised at, older patients are logging into Zoom for a clinic follow-up visit. Again, with the MAs helping us in clinic doing that, they're actually dealing with a lot of the oh, my camera won't turn on kind of thing. But by the time we get to them, it's actually pretty smooth most of the time. And so I think, we need to be mindful of who we might be missing, certainly. But in general, when we've had people willing to participate in this system, and that goes from top to bottom, that goes from, the ancient provider at my hospital who's never used a computer without a keyboard attached to it, to grandma who's out in Yakima, Washington with a burn injury. It's worked. And so I think that, again, making these things super accessible, super easy and straightforward to log into and use has gone a long way in the adoption of it, both from our patients and from our providers.
Well, thank you for such a fantastic presentation and discussion, and everyone who has joined us today. We would like to present you with a prestigious Tesla TRC Challenge coin, which you'll receive in the mail. It's, I can't magically make it go through Zoom yet. Part of telehealth, if I can do that, I'd solve a lot of telehealth issues, right?
Yeah.
But telepharmacy would be a lot easier if I could just get you something through Zoom, right? So, Thank you for your wonderful webinar, your pioneering contributions to advancing telehealth and burn care and healthcare in general. It was very nice to have you with us today. Be sure to join us for our next presentation, which is Thursday, March 28th. We will have two providers from Stanford, Catherine Hu and Rana Modir, as they talk about nutrition in telehealth. More information and the registration link will be available on our website and the social media soon. Thank you for joining us and have a great rest of your day.
Thank you all so much.